Now, the topic today is how to assess patient's effort during assisted mechanical ventilation. Why are we worried about how to assess the patient effort during assisted ventilation? During controlled mechanical ventilation, we know what happens. We look at the ventilator, and the pressures of the ventilator tell us roughly what's going on the lung of the patient. Then we have to make computations, esophageal pressure, but we know that if the airway pressure is 50 centimeters of water, something is wrong. With spontaneous breathing, the muscles of the patient are giving a variable contribution to transpulmonary pressure because the muscles pull the chest outwards, making a negative pressure around the lung. But we do not know how much negative pressure the patient is doing unless we do something either to measure it or to guess it. We are worried about transpulmonary pressure because transpulmonary pressure is the pressure that inflates the lung. Is the pressure that blows up the lung is transpulmonary pressure, the difference between the inside of the lung and the outside of the lung, which is the pleural pressure. The difference between the airway pressure and the pleural pressure is transpulmonary pressure. We make a good guess of the airway pressure, but we are not so good in guessing the pleural pressure. And transpulmonary pressure is particularly important as a damaging mechanism in non-homogeneous lungs. We've seen a lot of slides yesterday about non-homogeneous lungs. And this is another one. If you have a lung partially inflated, partially deflated, at the interface between the inflated lung and the, wow, we got a pointer. At the interface between, is a red, is a green, is echo pointer. At the interface between the inflated lung and the deflated lung, there might be a huge stress. You remember those drawings with the forces multiplying at the interface between, I think Gattinoni showed them. Very old papers, very old computation, but real life. Now, in the high respiratory drive patient, transpulmonary pressure might become very high because of the muscle effort of the patient. When the NIH, when the US government sponsored the low tidal volume versus high tidal volume study, a few investigators noted a strange side effect. You know that in the US, assist control mode is very common. It means the patients are not paralyzed and they can make spontaneous effort during controlled mechanical ventilation to trigger the ventilator. These investigators reported that when patients were ventilated in assist control with low tidal volumes, some of them developed acute pulmonary edema. Low tidal volume, in general, is very good, much better than 12 milliliters per kilo. But if the small tidal volume is coupled with high ventilatory drive, the patient wants to breathe fast and deep. And what happens? It happens that the patient makes huge drops in intrathoracic pressure. And the negative intrathoracic pressure causes pulmonary edema. In the most severe cases, hemorrhagic pulmonary edema. Because if the patient tries to breathe against an increased resistance or a stiff lung, sometimes that is not very good. And we have some other indications in literature that that is not good. You just heard, I don't have this slide here, the recent paper from Yoshida on critical care medicine this year, showing how deep and how high the respiratory drive can be in these patients. So we should be able either to monitor or to estimate or to guess with a certain accuracy the transpulmonary pressure in spontaneously breathing patients. Why? Not because we like numbers, but because we like to prevent ventilator-induced lung injury in spontaneously breathing patients. Because we like spontaneous breathing because it preserves the diaphragm, it preserves the muscles, it requires less sedation. It does not require paralyzers. If you have a paralyzed patient, don't attempt spontaneous breathing. But it might be bad too. And after all, we like to know how the patient feels, how much dyspnoic he is, and most of all, we like to tailor how much the patient is working and how much the ventilator is working. We don't care much about the energy expense of the ventilator, but we should care about the work of the patient. I think one of the simplest measurements is PO1. Most ventilators provide a measurement of PO1. PO1 is a strange name. It measures the amount of effort the patient is going to put into next breath. It exploits the fact that our brain drives the muscles. The example most common is when you go to lift a heavy bag. You go there to lift the heavy bag, and your brain tells to your arm that the bag is very heavy. If by chance it happens the bag is empty rather than heavy, you immediately feel out of shape because the force you apply is not of the proper amount. It's like when you push an open door. And if you think the bag is very light and you try to pull it while it is full and heavy, you will lose some time to adjust the force you need. If you make a patient breathe against an occluded airway, the pressure will go down with the speed the patient thought necessary for an open airway. And it will go faster, if we go down faster, the more force the patient thinks he will need. And you can measure it in the airways or in the esophagus Obviously, it's much easier to measure it in the airways. You occlude, you make an end expiratory occlusion without the patient knowing it, and the airway pressure will go down at a speed higher the respiratory drive of the patient. This is a very old pressure tracing of a patient on spontaneous breathing. This is the esophageal pressure. This is the airway pressure. This patient has very little support at this time, and the pressure goes down very quick and very deep. This is a patient with much higher support, and the patient goes down slower because the drive is lower, because the ventilator is working much more in this condition than in this condition. We should adjust the ventilator to reach a reasonable PO1 if we want the patient to breathe. PO1 actually, I say, is a measure of the happiness of the patient. A resting patient has a PO1 of 1.5 centimeters of water per 100 milliseconds. A running normal man, at the end of a run, will have a PO1 of 5. If you measure PO1 on a RDS patient able to breathe spontaneously, not a severe patient, PO1 will be PO1 will be 5 to 8 centimeters of water at least. So he's breathing, putting into his breaths the same effort he would put if he were running. And if we apply pressure support, we might be able to bring this PO1 down to 1.5 and have him happy with it. What does it mean? It means that here the patient is dyspnoic, he's panting like running. Here, as far as breathing is concerned, he's as happy as sitting at a table drinking a beer. This patient will last breathing for days, probably. This will be tired, fatigued in a short time. And this is the relationship between PO1 and the work of breathing. It's an old paper from 1995. You can even use PO1 to decide when you can wean a patient, because patient with very high PO1 these are patients undergoing decreasing levels of pressure support. You see that patients weaned unsuccessfully have much higher PO1s than patients weaned successfully. Why? Because these are more dyspnoic than these patients. This is it's called pressure muscle index. Is an index that Dr. Foti invented some 15 years ago. And it's very simple, but often very effective. To make a short story, a long story short, or a short story long, depends how you tell it. During pressure support, the ventilator makes this amount of pressure, but the patient makes this amount of negative pressure inside the chest. If we close the airways at end inspiration, when the patient ends inspiration, if we occlude the airways at end inspiration, at this point, the patient will start to expire. He relaxes his muscles, thus he stops pulling. Why? Because it is end inspiration. He thinks he has to expire. But the airways are occluded. What happens? That now the pressure jumps up. How much does it jump up? It jumps up approximately of the same amount that the patient was pulling down before starting to expire. So this is end inspiratory force, end inspiratory pressure. It measures how much pressure the patient is still putting by his own muscles at the end inspiration. And you see here that if you do this end inspiratory occlusion in the same patient at different levels of pressure support, here you see some 36, it's not, some 26, 20, I can see it. Some high level of pressure support on a patient on PEEP. The PMI is very small because this patient is almost totally supported by the pressure, by the ventilator. Here it has less than a very small level of pressure support. At end inspiration, the pressure goes up 4 or 5 times more, 6, 7 centimeters of water. This is the amount of effort and of pressure that the patient muscles were doing at end inspiration. And if at end inspiration the patient is still working quite a bit, it means we are supporting him not enough. He is working too much. So we have to set a level of PMI, a reasonable level of PMI. 0 is too low, is almost totally supported. 10 is too much. Now, this is estimating the patient effort by using airway pressure. No special tricks. All you have to use is either the inspiratory hold button or the expiratory hold button. The expiratory hold button gives you PO1. The inspiratory hold button gives you PMI. But you can do it very, very complicated using esophageal pressure. And you can even measure respiratory work. Measuring respiratory work is quite difficult. You need special tools. For time being, respiratory work is a research tool. I show you this slide and I go ahead. Next to respiratory work, we have pressure time product of the respiratory muscles. You need an esophageal pressure. This area you have to integrate the negative pressure over time. It tells you how much the patient is really working. It's not the physical definition of work, because you should be integrating it over volume. But if you integrate it over time, you get a much closer estimate of how much energy the patient is using. If you hold a bag at this level, fixed level, work is 0, because there is no movement. Work requires displacement. But you get tired anyway, correct? So if you measure for how long you maintain a negative pressure, you have a better estimate of the oxygen consumption of the muscles with the pressure time product than with the mechanical work. You see how bad is this relationship and how much better is this one? So pressure time product is quite a good measurement of how much energy the patient is putting into his breaths, but you still need a working esophageal pressure. And we know that esophageal pressure is a tricky measurement. The good part is that you don't need absolute pressure, you just need delta pressures, how much the pressure drops down. You don't care if it is 10, minus 10, minus 20. All you care about is the drop. You can measure directly oxygen consumption. And during weaning, or if you decrease the support, usually common knowledge tells you that if you decrease support, oxygen consumption increases. Why? Because the patient has to work more. Measuring oxygen consumption is another tricky business. However, I would like to discuss this point. Weaning failure is associated with an oxygen consumption higher than the oxygen consumption of a success weaning. But I think there is something behind it that we should consider, and we should look at it in a different way. We did an experiment going down from 20 centimeters of water to CPAP and measuring oxygen consumption. It's more tricky than that because you need to randomize, but I don't care about the experiment. The experiment is published, and you might go reading it, the technicalities. What I care about is the message. We measure oxygen consumption at different levels of pressure support in different patients. What happens? That one patient goes like this, going from 20 to 0 pressure support, has an oxygen consumption like this one, another one like this one. But you can identify a level where oxygen consumption is minimal. For this patient is here, for this patient is here. This patient has it at 12. This patient has it at 16. Now, first of all, patients that succeed weaning ever have a lower oxygen consumption than patients that fail weaning. That we knew. Why? Because patients failing work desperately to breathe, but they cannot succeed. Success patients reach a level of oxygen consumption which is lower than failing patients. The load on the failing patient is higher. But, can you see anything? Yes. If we plot oxygen consumption around the minimum level of oxygen consumption, we see that it's true. Success patients start from different level of oxygen consumption than failure patients. But the change in oxygen consumption is much higher in patients that succeed. Once again, success patients start from a lower oxygen consumption, but they are able to increase it very much, as needed, while failing patients start from a higher level and are not able to increase it any sizable amount. It's like athletes. Trained athletes can increase very much their oxygen consumption, and they succeed. They win the game. Athletes not trained uses up more oxygen because they are fat, they are heavy, but they cannot increase enough their oxygen consumption to succeed. But so much for oxygen consumption. I think oxygen consumption for time being is not a day-to-day practice, even if we have ventilators that measure oxygen consumption. But I think the real stimulating new things here is diaphragmatic electrical activity. This is non-invasive measurement of the activity of the diaphragm. I am not talking about NAVA. I'm talking about what we can do with the electrical signal coming from the catheter we use for NAVA. I'm talking about the electromyographic signal coming from the diaphragm. You know that we have the possibility of recording and reading continuously the electromyographic signal of the diaphragm by using a special catheter and the dedicated ventilator. But in theory, this could be done independently of the ventilator. The electromyographic signal is higher the higher the pressure developed by the diaphragm. Little force corresponds to small few microvolts. Big force corresponds to many microvolts. And we can have, unfortunately, in different patients, we have a different relationship. These are 3 different patients. You see that the relationship between the electromyographic signal and the pressure developed by the muscles is quite good. It's a pretty straight line. But these lines are different from patient A to patient B to patient C. I know that if the signal increases, probably in that patient, the developed force is increased. But I cannot compare this patient to this patient. Now, we played a little trick. In each patient, we have a relationship between the pressure developed by the muscles and the electromyographic signal. Unfortunately, we need esophageal pressure to know the pressure developed by the muscles. And so, again, we are stuck with this damn esophageal balloon story. But if we make an inspiratory occlusion, like in here, in this side, the airway is occluded. The patient inspires. He makes a negative pressure. But the volume does not change because the airway is occluded. So if the balloon is properly positioned, changes in the airway pressure equals the change in the airway. But who cares? I don't care about the balloon. If it's true, it is true, it is physically sound that with the airway occluded, if I measure the change in pressure in the airways, this tells me what is the change in the pleural pressure. So if I occlude the airways, if I measure -10 here, it means in the esophagus I have -10. Good. But if this -10 on the airways, if I plot it with electromyographic signal, I can now make a relationship between the airway pressure, which equals the esophageal pressure, to the electromyographic signal. What I'm saying that I can, if I play the trick of an inspiratory occlusion, I can calibrate in each patient the correspondence between microvolts and centimeters of water without the esophagus, because I have calibrated it with the inspiratory occlusion, then does it without esophagus, because by definition, during inspiratory occlusion, the change in pressure in the airway equals the change of pressure in the pleural pressure. Now, if I have a patient and I measure the electromyographic signal, I can follow breath by breath how many microvolts the patient is putting into his diaphragm. And if I know in this patient, in Giuseppe 40, 1 microvolt is 3 centimeters of water. So when I see 10 microvolts, I know he's making 30 centimeters of water, minus 30 centimeters of water in his chest. And so he will have minus 30 in his pleura. The transpulmonary pressure will be minus 40 if it has 10 of PEEP. But most of all, his muscles are working to generate minus 30 centimeters of water. This simply by measuring the electromyography of the diaphragm and doing an inspiratory occlusion to calibrate it. Obviously, is a little bit more complicated than that, but the inspiratory muscle pressure can be calculated as the product between EAdi, the electromyographic signal, and the relationship, the constant that relates pressure and volts. Is feasible, is doable at the bedside, and up to now, it provides reliable clinical data. The important message is that continuous diaphragmatic monitoring is a tool that we can use to do NAVA, if we want to do NAVA, or that we can use to understand what's going on with the muscles of our patients independently for NAVA during pressure support or proportional assist ventilation. So, in summary, how can you estimate the inspiratory effort of your patients? You can do an end expiratory occlusion and measure PO1. You can even do it automatically in your patients. Most ventilators do it. You can push the end inspiratory pause and measure PMI during pressure support. You can measure oxygen consumption, but that is very complicated. You can use an esophageal balloon. It's not always very reliable, particularly for days. Or, and this is new, but validated, you can use the electromyography of the diaphragm. And that is all. Thank you. I would like to take questions, but I think it's better if we move to the hands-on session. And please come back here at 12:30. We'll have lunch here and we'll discuss a clinical case with Giuseppe. Thank you.
Okay, so Group E with Dr. Piquillo, Group F with Dr. Iotti, Group A with me, Group B with Dr. Aguirre Bermeo.
B for boy.
B for boy, or Boulogne. Group C with Dr. Akumanaki, and Group D with Dr. Foti.
Yup, 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 up, up, up. Okay.